Hi, this is Brian Kim. I want to share with you case number 271 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so that you can provide the very best for your patient. So this is a 90-year-old patient, hypermature cataract, and you can see I'm going to perform terminal chop, cross chop, mechanical fracturing techniques, trying to maximize and leverage mechanical fracturing forces to minimize ultrasonic energy damage to the corneal endothelium. Also be able to protect the capsule with these techniques. As you can see, this is a rather dense lens. It's a pretty dense lens. This is the left eye. You can see the patient has a strong Bell's reflex. Using the cotton tip to steady the eye and center it. Using a corneal marker, which will help me to center and size the rexus. You can see the patient's resisting me a little bit. Asking the patient to look down. And this is my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to iris plane. These are our angled diamond blades from Diamatrix. Make a flat approach. This creates a nice corneal shelf, which will allow me to create a self-sealing incision. I'm just adjusting the speculum. These are from Epsilon. These are the narrow wire speculum. Injecting some intracameral epinephrine and then some air and then trypan blue. With these super dense lenses, it makes a whole lot of sense to put some trypan blue because you just can't trust the integrity of the capsule or the zonules. Pushing some dispersive viscoelastic to fill the chamber. Using the Orlock technique to twist the incision with a cannula and turning the eye down so I can control it for my main incision. This is the triplanar corneal incision. I make a vertical groove. Place the blade into the deep part of the groove, tunnel through the cornea. And then when I'm ready, I can turn down, wiggle, 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 and then I enter. Again, still employing the Orlock technique, twisting the cannula within the paracentesis incision to keep the eye nice and down. And these are the Moria rexus forceps. I puncture the center. These are sharp tip. Pull down towards me, grabbing the right side of the tear. Going around circumferentially. These low profile forceps are fantastic. You want to make a rather big rexus in these cases, relatively big rexus with these hypermature lenses. So you can see I'm making a rather big rexus. This increases your leverage when you're trying to chop. These lenses are so big that when you place the chopper out to the equator, sometimes the lens is just so bulky. Placing some viscoelastic on the corneal surface. This is the capsule fornix hydrodissection technique. I place a cannula under the rexus edge contra-incisionally. Again, these are super dense, and normally with dense lenses, the lens is already loose. And as you can see, the lens spins rather easily here. So with these super dense lenses, I always perform a terminal chop. You want to create space. You don't trust the zonules in these cases. This is a 90-year-old patient. So I'll lift the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface lens material. Turning the tip up now, go to sculpt mode, and then let's go ahead and start sculpting the trough here. You can see I'm really trying to push, and it's a little bit bouncy. Trying not to exert too much stress on the zonules as I do this. I'm just kind of gently just pushing little by little. Nothing particularly exciting at this step. Turning the lens 180 degrees. Sculpting some more. Again, I'm very mindful that I'm not pushing too hard as I do this. Switching to quad mode now. Let's going to go ahead and perform the terminal chop, see what happens. Placing the chopper under the rexus edge contra-incisionally, hooking the peripheral lens, crushing it from the periphery, separating with lateral forces. And you can see now it's starting to come apart. Turning the lens 180 degrees again. So you can see the lens is rather loose. Placing the chopper around the contralateral fornix, and again performing another terminal chop, and now it's separated. Placing the chopper under the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phagocyte, which is placed deep between the two pieces, and then getting separation. Placing the chopper under the first quadrant, pulling it centrally toward the phagocyte, fracturing it again, grabbing that first fragment up, crushing it between the instruments, and then carefully emulsifying the lens piece. Doing the same thing with that fragment, grabbing it with some vacuum, crushing it between the instruments, and once the pieces are small enough, emulsifying it. It's a very controlled, methodical way to disassemble the lens. Because I know how to hook the lens pieces up out of the bag with the chopper, I never feel like I'm in trouble. I know that I'm able to get the lens pieces out. I know that I can manipulate my instruments in such a way that I can access the lens pieces to be able to effectively grab the lens pieces and fracture the lens pieces into smaller pieces and then emulsify the lens pieces. Knowing that I'm able to have the techniques to do this gives me a lot of freedom and confidence when I'm dealing with these tough cases. So I turn the second heminucleus in front of me, pushing some more dispersive viscoelastic to coat the corneal endothelium. Placing the chopper again back into the eye, placing the chopper under the contralateral fornix, pulling the chopper centrally toward the phagocyte, fracturing that second heminucleus in half. Placing the chopper under the third quadrant, doing the same maneuver, hooking the peripheral lens, pulling it centrally toward the phagocyte, and then again fracturing the lens piece in half. Grabbing that fragment with some vacuum, positioning the lens piece on the tip, and then hooking the lens with the chopper, flanking the lens piece, crushing it in half, essentially slicing it, and then emulsifying the lens piece. Using some vacuum to grab that fragment, and then again crushing the lens with the instruments into smaller pieces, and then emulsifying. Grabbing that other piece with some vacuum, doing the same thing, crushing the lens piece into smaller pieces using mechanical forces, and then emulsifying it. Placing the chopper around the last quadrant, hooking the lens from the periphery, pulling it centrally toward the phagocyte, and fracturing that lens piece in half. Again, doing all this purely with irrigation fluid. This helps minimize your risk to the cornea as well as the posterior capsule. Using some vacuum to grab the piece and then getting the chopper around the lens piece and then crushing it once again. Knowing your way around the capsular bag is very important. Knowing that the chopper is in a safe place, knowing that you're just hooking the lens piece, getting around the lens piece so you can make sure it doesn't want to run away from you. And I'm able to crush the lens piece into smaller pieces, turning the chopper sideways so it's not pointed down, being able to visualize everything very clearly, making sure the chopper is deep to the phagocyte, and then eating the last pieces. So I take the chopper out, push BSS in, take the phagocyte out, and I go in with the INA handpiece. Switch to cortex mode, starting subincisionally, peeling from anterior to posterior. You can see that the bag is rather clean. You can see there's some posterior capsule fibrosis. There's some cortex there. Use the polish mode to polish under the rexus edge, going around, sweeping side to side. Again, there's some posterior capsule fibrosis, which I'll leave. Pulsing BSS into the subincisional capsule fornix. Not much there. Looking pretty good. Turn off infusion, pushing cohesive viscoelastic to fill the bag, and then using the sweeper to polish under the rexus edge. But as I do this, look, I see something hiding on the left side. And lo and behold, there's a large endonuclear nugget. So I'm able to pull that piece up and then go in, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Turning on infusion. Make sure I don't lose that piece. Using vacuum to grab the piece at the tip. Carefully crushing it with the chopper and then emulsifying the lens piece. So with these super dense lenses, you have to be careful of hidden nuggets. Turn on infusion and push cohesive viscoelastic once again. Start over with the sweeping. And then now I see another piece. You see that? Subincisional, I'm using the sweeper to slide. As I do this, you can see another piece is emerging. So the sweeper is very effective in so many ways. I'm able to sweep under the capsular fornix, under the rexus edge, but in this case, I was able to sweep these lens pieces up. So I'm able to get that piece up, start again, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, grabbing the piece with some vacuum and then eating it up. So I take the chopper out, pushing some cohesive viscoelastic to fill the bag for the third time. And then I'm polishing under the rexus edge on the left side. And then I'll do it on the right side. So again, most of that CDE occurred during the sculpting. So able to be mindful with the mechanical fracturing forces, cross chop, doing all those techniques. Again, in the beginning, when you're sculpting, the corneal endothelium is fully protected during that part of the case. So endothelial trauma should be minimized. This is a single piece acrylic lens. It's going into the bag. The bag and the zonules actually felt pretty good. So I felt pretty comfortable putting in this single piece acrylic lens in this 90-year-old patient. Going in with irrigation off, activating irrigation, removing the bubbles. Getting underneath the lens, tilting it up, removing all the viscoelastic from within the bag. This patient's probably going to need a YAG at some point. Probably give it a few more months to let the capsular bag stabilize. And since I made such a big rexus, I just want to make sure that the lens is completely in the bag, that both haptics are in the bag, using the Maltzman to check. Removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a hypermature cataract. The tips are, I used a sculpting technique to perform the terminal chop. So I sculpt a deep trough, debulk this super dense lens, and then I was able to perform terminal chop. I was able to effectively fracture the lens in half using the technique, and then performing cross chop, which minimizes any zonular stress. I'm able to fracture the lens, get the chopper around the lens equator, hooking it, and then pulling it centered toward the phaco tip, fracturing the lens in half. I'm able to do this over and over again, multiple steps, and then crushing the lens piece into smaller pieces. You have to be mindful when you're dealing with these super dense lenses. You can be having lens pieces hiding under the iris. So you have to have a high level of awareness. As I was able to disclose this and pull up the lens pieces using the sweeper. And then, of course, at the very end, I used the Maltzman to retract the pupil to see if there was any other pieces. And so be mindful of lens fragments when you're dealing with these hypermature lenses. Minimize ultrasonic energy and vacuum. Perform mechanical fracturing techniques to get clear corneas in these cases. And hopefully this 90-year-old patient will be seeing better after surgery. So I hope this was helpful to you, and I thank you for your attention.